Hi, everybody. Today we're looking at Chapter 21, the respiratory system. So what does the respiratory system do? What are its functions? It has a large amount of surface area to allow for gas exchange between air and blood. It's going to help move the air to and from those exchange surfaces. And we need to protect those respiratory surfaces from dehydration, temperature change, and pathogens. It helps us produce sounds, and it also helps us detect odors. And we learned a little bit about that last year in AP1 when we studied the olfactory special senses. So the respiratory system is divided into an upper tract and a lower tract. And these are structures involved in breathing, pulmonary ventilation, and then gas exchanged. So we've got the respiratory tract. This is a large amount of the upper portion, and it is the conducting portion. So this is how we're going to get that air to and from the exchange surface. There's no gas exchange occurring here. It's just for transport. And so this moves from the nasal cavity to the bronchioles. And then we've got the respiratory portion where respiration is actually happening. And this includes the respiratory bronchioles into the alveoli. So we have a way to get the gas to those alveoli, and then we're going to actually have gas exchange occur there. So here is an overview of the respiratory system. We start here at the nose and the nasal cavity. We've got some sinuses that we're going to talk about here, and then also the pharynx. We have our larynx or larynx where we're going to, nope, we cannot do that. Okay, we'll try again. So here we have a diagram of the respiratory system and its different divisions. The upper respiratory system includes the nose, the nasal cavity, the paranasal sinuses, and the pharynx. And then our lower respiratory system is going to include the larynx, the trachea, the bronchus, and the bronchioles. So let's talk about the anatomy of the respiratory system. We've got upper and lower tracts. So these are divided between the structures that are involved in breathing and pulmonary ventilation. So that's getting the air to the sites of gas exchange, and then the actual sites of gas exchange. So the respiratory tract is the conducting portion, and that goes from the nasal cavity to the bronchioles, and there's no gas exchange that occurs here. And then we have the respiratory portion that's going to go from the respiratory bronchioles all the way down to the alveoli, and that's where we're going to have the actual gas exchange. So let's look at an image of this. Here is the upper respiratory system, where air will go through the nose to the nasal cavity. We're going to talk about the paranasal sinuses and the pharynx. And then the lower respiratory system includes the larynx, the trachea, the bronchus, the bronchioles, the respiratory bronchioles, and then the alveoli. So you want to know which structures are involved in which system, what is the upper respiratory system, and what is the lower respiratory system. And you want to know the flow through those systems. So take a minute to look at this question. You can pause the video if you need to. So oxygen-rich air inhaled into the respiratory system will travel from the trachea immediately next to the primary bronchus. So it will have already been through the pharynx and the larynx, and after it moves through the primary bronchus, it will go into those bronchioles. So we need to defend this system from bacteria and particulates. We need to protect that mucosa. And this is our respiratory defense system. It lines the conducting portion of the tract. So as we're taking the air to those areas for gas exchange, we're getting rid of anything that could get in the way. and it's made of pseudostratified ciliated epithelium with mucus cells. So remember, pseudostratified means it looks stratified, but every cell actually does reach to the lumen. Um, and we've got these mucus cells that are going to help catch things in it so that they don't continue to go deeper into the respiratory tract. So the mucus cells are between the epithelial cells. So they're individual cells in that epithelial layer. You can see the cilia here that are going to beat. You can see some stem cells that will help regenerate these pseudostratified epithelial cells. We've got our basement membrane, and we've got our lamina propria. And in that lamina propria, we're going to have larger mucus glands that are going to produce even more mucus. And you probably can experience that mucus if it's creating more than usual with an infection. If you have a runny nose or a cough, you're seeing those mucus glands in action. This lamina propria is underlying areolar connective tissue that's going to support the epithelium here. And we really see these mucus glands in the upper respiratory tract and then in the trachea and the bronchi. They're very prominent. So we have what's known as cilia, and it's going to sweep mucus, and with the debris that's caught in it, towards the pharynx, where it's going to be coughed up or it's going to be swallowed. And we call this the mucociliary escalator. It's the escalator that all those debris are going to take out of the body. Now, some parasites have realized this and have used it to their advantage, specifically hookworms. In dogs, we think of hookworms they get from being near the ground, and they're always sometimes eating dirt, and they can get some hookworm eggs. But you can also get hookworm eggs in humans through the skin. And no matter if you're a dog or a human, the hookworm egg gets in, and it's going to migrate to the respiratory system first, which seems a little counterintuitive because hookworms are parasites of the intestines. But they know the system that we have, and so they get into the respiratory system. They get on this mucociliary escalator. They ride it up to the pharynx where they're coughed up and then swallowed, and that's their path to the intestines. So the importance of having your pet on a preventative for parasites, they are very common here in Florida, and I don't recommend being outside dealing with the dirt with bare feet or open cuts and sores, because there's the chance that we as humans can get them too. So the respiratory epithelium does vary some based on location and function. So here we are in the nasal cavity where we have that respiratory mucosa and those mucus cells. In the pharynx, there's actually stratified squamous epithelium. We're getting some food from the oral cavity there. There's the chance for abrasion and some harsher chemicals, and so that's going to help protect that area. We're back in the larynx and the trachea with our respiratory mucosa and mucosa cells, or mucus cells. As we move deeper into the narrow bronchioles, we're going to end up with this cuboidal epithelium. We saw this in AP1 lab. And then in the alveola or alveoli, we're going to have simple squamous epithelium. So one single layer of tissue that allows for gas exchange. So too much mucus isn't good. Not only is it annoying for you when you're sick, but there are diseases that can make too much mucus a permanent and constant problem. And one example of this is cystic fibrosis. This is an inherited disease. It's recessive genetically from people mostly of Northern European descent. And in this case, the mucus is too thick and sticky to go up the escalator. So it gets trapped in those lungs. And then it also ends up in the alveoli where it's going to block gas exchange. This means that we can't get rid of pathogens. And if we do have pathogens, they're going to get stuck in the sensitive portions of the respiratory system down in those alveoli. So we've got increase in infections, specifically Pseudomonas. Those can be some really nasty opportunistic infections. So the goal of this is to use treatments to thin mucus, or things like coupage to try and encourage the mucus to move and get out of that respiratory tract. However, the lifespan is decreased. So its average lifespan is around 37 years old. And the cause of death is usually heart failure, but that's secondary to a really massive chronic bacterial infection. So the disease leads to infection, and then that puts too much strain on the heart. So let's look at the upper respiratory system specifically. Remember, it's the nose, the nasal cavity, the paranasal sinuses, and the pharynx. The air enters through the nose, and you have the nasal concha, or that are going to cause some turbulence. So they're called concha because they look like shells. Think of conch shells. And the goal of that, though, with the turbulence is it's going to get more particles trapped in that mucus, and it's going to warm up the air and moisturize the air, so that it's going to not be dry, be less irritating, be closer to body temperature for us. There is a lamina propria that has a extensive vein network, and that vein network is part of that warming of the air. And in that nasal cavity, that's where we're also going to get the olfaction or the smell. And the mucus in our nose comes from our paranasal sinuses. And those sinuses are in the maxillary, the frontal, the ethmoid, and the sphenoid bone. So we want to make sure that we know what the paranasal sinuses are and where they're located. So if we look here at this cross section, so this is a coronal section. You can see the eyes here. We see the nasal concha in the nasal cavity, and then we can see the sinuses. So we've got the frontal sinus here. In the frontal bone, we've got ethmoid sinus, that's a bilateral one. And then we have the maxillary sinus here, again, bilateral. You can see here's the hard palate, and now we're in the oral cavity with the tongue here. There are meatuses, so there's an inferior, a middle, and a superior that are pathways that kind of go between these concha to let the air move. And you can see the concha again creating that turbulence so that the particles can be trapped in the mucus, the air can be warmed and can be humidified or pick up moisture on the way in. As air exits, that nasal mucosa is going to try and reabsorb that heat. We don't want to lose too much heat, and reabsorb that moisture from the exiting air in order to keep homeostasis. However, this can change. If we are breathing through our mouth heavily, we're going to lose a lot more heat, and we're going to lose a lot more moisture because it's not passing through these nasal concha to have that reabsorption happen. So looking at this quiz question, take a minute to read it and pause if you need a moment to choose an answer. So the true statement here is air moving from the nasal cavity to the lungs is heated almost to body temperature. Again, part of maintaining that homeostasis. If we breathe through the mouth, we're going to have more water and heat loss. And as air moves out of the respiratory system, it's actually going to give back some of that heat and moisture. Little veterinary story here. The anatomy for horses and humans, as far as the frontal sinus and nasal cavity, not exactly the same, but you'll be able to appreciate it from this image. Early as a veterinarian, I was spending some time with a veterinarian in the country, in rural Texas, and I got to see some horses with him. And there was a horse with this terrible, terrible, terrible sinus infection, incredibly thick mucus. The infection was deep into the mucus, which couldn't be removed from the sinus. And the horse was really having long-term issues. And so we're not in a fancy clinic where we have, a big endoscope and can go up with the endoscope to look in the sinuses. But doing some research, there has been experiences with flushing those sinuses. And the doctor I worked with was willing to try. We looked at all the literature. And so what we did, and it was wild, we numbed the bone in that area. So we numbed the bone above the frontal sinus of the horse. And then we used a medical drill. It was sterilized, something they might use for bone surgery. And we drilled a hole in that sinus. And the horse didn't feel anything. It didn't have to be put to sleep. It was awake, but it was totally numb. And then into that little hole, we were able to push some sterile saline, and we could push it through with a little bit of force. Not too much, but enough to hydrate the thick mucus and to get it moving. And what happened was that sinus is connected to the nasal cavity. So as we push that mucus out, it went into the nasal cavity, and then the horse would hold its head down and the mucus would flow out of its nose. And when I say I saw the biggest, thickest mucus booger, it was so satisfying to see it all come out. It was more than probably 2 cups of mucus from each nostril. And it just came out in big, thick strands to make that horse feel better. Worked very well, and an example of using the literature and using others' experiences to do what was needed in a situation where we didn't have access to the most ideal therapies. So reminding us also that the frontal sinus is where that mucus comes from that goes into the nose. A little bit more about the upper respiratory tract. We have the pharynx, and this is the shared chamber between the digestive and respiratory systems. And so there's 2 parts of it. There's the nasopharynx, which is the respiratory part. It is the more superior part. So we've got it right here, that nasopharynx, and that's where the auditory tubes exit. So right here, those eustachian tubes where you can get drainage from or help equalize pressure. And then you have the oropharynx, which is the part related to the oral cavity. And in this, we've got this change in epithelium from the oral cavity where we're going to go towards stratified squamous epithelium. And then there's a last little part of the pharynx called the laryngopharynx. So this is a little bit further down towards the larynx, and it's between the hyoid bone. So we've got our hyoid bone here where our tongue's going to attach. Remember, it's that little bone that doesn't attach to other bones but has soft tissue attachments. And it's going to be between that bone and the entrance to the trachea and the esophagus. The oropharynx technically runs from the soft palate. So here is your soft palate. There's no bone here to the base of the tongue. But these are all connected. If you hear people talk about postnasal drip, that's the drip that's coming down through this pharynx here. So different parts of the pharynx we want to be aware of. So we've got an image here. This tracks all the different components of the respiratory system, really helpful for you to label as you practice tracing the flow of air through each component. And then there's also a slide with the answers, and you can see we've done numbers 1, 2, 3, and 7 thus far. So we've done the upper respiratory tract, and we're going to look at the lower respiratory tract, and this includes the larynx, the trachea, the bronchus, the bronchioles, and the alveoli. And the pathway we're going to go through is first the larynx. That's going to help protect the glottis. We're going to go through the trachea. That's the windpipe. The bronchi, there's 2. There's a left and a right bronchi. And those are going to divide into lobar bronchi and then to segmental bronchi. And from those segmental bronchi, we go into bronchioles. The word means little bronchus, and then terminal bronchioles, which are going to take us even further to the pulmonary lobules, through the respiratory bronchioles, and then to the alveoli. So we'll go through each one step at a time. So here's the larynx, and then goal of that is to protect the glottis. It's a cartilaginous tube that surrounds the voice box. You can feel it. And you have a piece of cartilaginous tissue called the epiglottis. That's what covers the glottis when we're swallowing, so food doesn't enter that respiratory tract unless you speak while you're chewing and swallowing. And only one opening, either the esophagus or the trachea, can be open at a time, and that's where you have the risk of choking or having food go down the respiratory tract. So looking here, we've got several large cartilages to be aware of. We have our epiglottis. We have the large thyroid cartilage here. We've got the more inferior and smaller cricoid cartilage. And then there's the arytenoid cartilage, which is located deep to these things. Here's our trachea, and these are all linked by a variety of ligaments. Here's that hyoid bone, again, that's going to help hold these structures with ligaments. Now, your glottis is made up of your vocal folds and your rima glottis. And we can see here in this image, here's your glottis. You've got the rima glottis, which is the actual hole, and then you have your vocal folds, which surround it. And the passing air will vibrate those vocal folds, and that allows for sound waves to be produced. And that process is known as phonation. Comes from the same root word as phonics, if you're aware of that. The pitch is going to depend on the diameter of those bones, the diameter of the glottis, the length, the tension in those vocal folds. And there are voluntary muscles that surround the cartilages that are going to help control that tension. So here you can see several of those cartilages. You've got your corniculate cartilage, your cuneiform cartilage, your aryepiglottic fold. Here's that epiglottis. It has this distinct kind of rounded or depression shape that pokes forward, and here's the root of the tongue, and then the vestibular folds are what is connecting these vocal folds partially to some of these cartilages. You can see the glottis when it's open, and you can see the glottis when it's closed. The rima glottis is not there because there's not an opening. And then sounds are modified by the tongue, the teeth, the lips, and even the sinuses as well. When you hear people talking about putting a trach tube in or having someone be intubated, this is part of what that process is you want to go in over this epiglottis. You're going to go through the glottis with that tube. That's going to hold these vocal folds open and create an airway that can be used in case someone's having swelling there, if we're undergoing anesthesia and are going to use some kind of gas anesthesia, wide variety of reasons why you might need that tube, but this is what the goal is to have a tube go through into that respiratory tract. And when we think of sounds that are modified by tongue, teeth, lips, and sinuses, I think of Barbra Streisand. I know she's probably a little bit before everyone else's time, but she did Hello, Dolly, and Funny Girl. If you look, she had a very prominent nose, and she was always very self-conscious of her nose. But she went to some plastic surgeons and some ENTs and talked about having a nose job done. And they said, no, we will not do it, because if we change your nose and change the sinuses in any way, your voice will change. And her voice was so famous at the time and so impressive that she ended up not having the procedure done. So interesting connection to phonation and the glottal area and the sounds that we have. So next, air is going to move through our trachea. It is tough but flexible, and that's because it has these rings of cartilage. They're going to help hold everything open, but then between the rings of cartilage, there are muscles there. And so that gives it its flexibility. It runs from the 6th cervical vertebra to the 5th thoracic vertebra, and it is pseudostratified epithelium with those cilia. There are 15 to 20 of those cartilage rings, and again, the muscles that they're attached to can constrict and narrow the trachea, and that's what allows us to cough. And so your esophagus does sit very near your trachea. A big problem if someone gets something very sharp and pokey in the esophagus, there's the chance it can poke through to the trachea. Less of a problem in humans than animals, but still important to realize how close these are together. Here is the trachealis muscle. So these rings are not complete circles. There's a muscle that runs between the free ends. You've got your mucosa here, the lumen, you have your tracheal cartilage, and then here are some of those glands producing that mucus as part of the defense system. From the trachea, so you can see the cartilages and how they're going to help it be structured but flexible. We're going to move into the bronchi. The bronchi are full rings of cartilage, so no longer C-shaped. And the trachea is going to split at the level of T5 to form the left and right bronchus. Bronchus is the singular form of bronchi. And you can see the right is more large in diameter, and it's a little bit straighter than the left side. The left side's a little smaller and has this curve. And important because this is where if someone inhales something or someone is choking, this is where those foreign objects are going to end up. This is just a perfect, nice, straight pathway down to where we've got this division. And at that division, it's going to get stuck there. So something important to realize in situations of emergency where things might get stuck. The left, we said, is smaller and angles off, and because of that, it's a lot harder for things to fall into it. I do want to point out here, very important to know about the carina. This is where you've got that bifurcation into those right and left main bronchi. It's a really important landmark on x-rays to kind of help locate where we are along the respiratory tract and where disease might be seen. So now let's look at the bronchioles. We're getting more significant decrease in the diameter. We've gone from our main bronchus, we've gone to our lobar bronchi, and then into our segmental bronchi. And these don't have cartilaginous rings, but there are little plates of cartilage there. And then from these segmental bronchi, we move into the bronchioles, where there's no cartilage, but there is smooth muscle. And this is a cross section, so you can see our respiratory epithelium, and then there is that smooth muscle, which is incredibly important because it allows for changes in the bronchial diameter. So if we have bronchodilation, where the airways are wider, you're going to get more airflow and have less resistance to airflow. And this happens with sympathetic activation. So with your fight or flight system, you want to be able to get as much oxygenated air and get rid of as much carbon dioxide as possible to keep responding to that threat. With our parasympathetic activation, so more rest and digest, we will get bronchoconstriction, where those airways will get narrower and there'll be a little bit more airway resistance. Asthma specifically involves swelling and constriction, which should read constriction. Let me change that here. Swelling and constriction that is going to restrict or impede airflow. You hear wheezing because those airways are so narrow, it's pushing to get air out and creating sound. And that swelling can be related to like an allergen, it can be related to inflammation. But when you get those airways narrowed, you can't get enough oxygen and you struggle to breathe. Interestingly, looking at treatments for asthma through the years, my dad is asthmatic, and when he was young, would have asthma attacks. But at that time, for really severe attacks, the treatment was epinephrine, which was given via injection and causes some really radical additional effects. So you're having changes in your blood vessels, your heart rate spiking, you're having changes in your blood pressure. So yes, you're able to breathe, and it's worth giving, but you've got some more effects to deal with. I inherited some asthma, and so growing up, we used more in the albuterol family through inhalation, which is great because you don't have to go through the systemic system. You can actually inhale it to get to those little bronchioles, and have that dilation happen. But it's involving sympathetic activation. And so the early inhalers also had some of those additional side effects. So with albuterol, you could get an increase in heart rate and feel your heart racing, because it wasn't selective for which receptors it hit. More recently, and by recent, I probably mean in the last 10 or 15 years, they have developed inhalers that only affect the receptors in respiratory tissue. They don't affect the cardiac receptors. So now you are less likely to have racing heart or other effects. Now, this is more our rescue inhaler category. There's a whole nother category about decreasing the reactivity and the inflammation, but interesting to see how medications change and how important those receptors are for things. So looking here, looking at the image from before, read the question and then go ahead and take a minute if you need to pause to give the answer. So each terminal bronchiole supports a single pulmonary lobule. I'm going to take us back to this image so you can see. Here is that pulmonary lobule. So your terminal bronchiole to your respiratory bronchiole, and that respiratory bronchiole is that pulmonary lobule. Once again, we have the image of the respiratory system. Good way to practice as you prepare for the exam. And you can see here, we've done the lower respiratory tract. These are the structures that we've looked at so far. But now we're going to look at the lungs. And we want to know that the right lung has 3 lobes, and the left lung has 2 lobes. The right lung, we've got a superior lobe, a middle lobe, and an inferior lobe. And in the left lung, we've got just a superior and an inferior lobe there. The lung lobes are divided into segments. And so you can see here where we've got the bronchopulmonary segments dividing off in each lung lobe. And then the bronchi and the bronchiole are going to form a little tree that's going to deliver the air to the exchange surfaces. And the bronchopulmonary segments go to a specific region of each lung. So that helps us, if we're seeing a problem in this region, we can know exactly which bronchopulmonary segment is in this location, and it might give us some information about what's causing the disease there. So a different view of the lungs and their lobes, couple of other cavities and landmarks we want to be aware of. The lungs are in the pleural cavity from rib 1 to the diaphragm. We want to know the lobes. So again, we've got our superior, our middle, and our inferior lobe in the right lung. And then our left lung, we just have the superior and inferior. There is an oblique fissure in each lung. But because there's 3 lobes in the right lung, we also have a horizontal fissure. Notice the apex is superior in the lungs, the base is inferior. So we've got a broad base and a narrow apex, a little bit different from the heart. So keep that in mind. Here in our left lung, we have the cardiac notch. This is the place where the heart is going to sit. And when we look at some medial views, we do want to be aware of the hilum. This is the groove that allows for passage of the main bronchi, the pulmonary vessels, the nerves, and the lymphatics. And this is where we call the root of the lungs. So this is where it's actually attaching to those bronchi. You can see in the right lung, we have the horizontal fissure and the oblique fissure, just an oblique fissure in the left lung because there are only two lobes. You can see the slightly domed diaphragmatic surface at the base, and then we have the apex here as well. And then on this left lung, you can also see there's this nice groove for the aorta, so it's got space to move down. So few landmarks we want to be aware of in the lungs. And this is where we get to our alveoli, which is the actual site of gas exchange. So they are very thin walled because we need things to move between them. We've got simple squamous epithelium, and that's pneumocytes type 1. So pneumo has to do with lungs, cells are sites, so lung cells. Type 1 is where the gas diffusion occurs. And then you've got pneumocytes type 2 that produces surfactant. And surfactant is a thin layer of water that has phospholipids and proteins over it that allow the lungs, when they are deflated, they don't get stuck to each other. It allows them to re-expand. You can kind of think about when you have saran wrap or cling film and it folds over onto itself, what a nightmare it is to try and get those two pieces apart and separate. Without our surfactant, we'd have something similar going on with our lungs. And then in our alveoli, we've got these alveolar macrophages that are roaming around and phagocytizing stuff, getting rid of any debris or pathogens that ended up getting down there. There are about 150 million alveoli, and they're surrounded by a really prominent capillary network, and we need that again for our gas exchange. These capillaries will dilate when the oxygen level in the alveoli is really high and constrict when the oxygen level is low, and that's going to direct our blood flow to the alveoli that have the most oxygen so that we can be most efficient. And then there's also an elastic network of tissue, and that's really important because it's going to help the alveoli recoil when we exhale. And it's going to, as it recoils, it's going to push that air out so that we're pushing more air out of the lungs. When we push air out of the lungs, that's going to give space for new air to come in. Okay, so let's look at a picture of these alveoli. Here we've got our trachea, our bronchus, all of our little bronchioles. We're going into our bronchopulmonary segment. Remember, this supplies one specific area of the lungs. And then we are going into our alveoli. Here they are. They're all these little sacs that appear. They're known as alveolar sacs or alveolar saccules. And they are surrounded by these capillary beds that are going to either bring the carbon dioxide to them or take the oxygen where it needs to be. You've got alveolar ducts that are part of bringing the air into these sacs or saccules, and the respiratory bronchiole is what brings the alveolar ducts, or excuse me, brings the air to the alveolar ducts. So you can see here we've got the pulmonary artery. So that's bringing us deoxygenated blood to be oxygenated. You've got a branch coming down here. It's wrapping around these alveoli, spreading into the capillaries. Once that gas exchange occurs, it's going to move over here where we've got a branch of the pulmonary vein to take blood back to the heart that it's oxygenated. You can see here is an interlobular septum that's going to help divide areas of the lungs. And then I also want to point out the pleura. Remember from AP1, you've got your visceral pleura that is attached to the organ itself. Here is the pleural cavity where you would have pleural fluid. And then you also have your parietal pleura here that is going to be against that chest wall. I want to go back for 1 second to look, well, we'll go forward and then I'll talk about this when we get there. Here we're looking at the different type of pneumocytes. We've got our pneumocytes type 1, that's that simple squamous epithelium where gas diffusion occurs. We've got our pneumocytes type 2 that are creating the surfactant of the lungs. We've got some alveolar macrophages that are moving around to engulf pathogens or debris. You can see the capillaries that are in between these alveoli alveoli with their little single layer of epithelium. You can see here is an interconnection between adjacent alveoli. You can see that really there's only two cell layers for the gas to move through. You've got your layer of alveolar epithelium, and then you've got your endothelium of the capillaries. So just two little cell layers to move through. And then here's those elastic fibers to help with recoil and to help push air out. What I wanted to point out was the pneumocytes type 2 and the surfactant. This becomes a huge issue with babies, and specifically premature babies. One of the last things that develops in a fetus's development is that surfactant. And that surfactant is what allows them, as they are born, to come out and their lungs will open up and they're able to make that cry and able to breathe. And if you don't have enough surfactant, the baby will be born but not be able to breathe because those lungs and those alveoli are going to be kind of stuck together and can't take any oxygen in. And so there are medications now that they can give to babies that they know are going to be born prematurely to try and help boost that surfactant production and help that surfactant to be produced earlier, so that even though they're premature and their body may not have yet made the surfactant naturally on its own, we're able to get that surfactant. So as they're born, they're able to get good airflow and have those lungs function well. So let's look at this question. Take a minute to read it, pause the video, select your answer. Hope you got that gas exchange surfaces are simple squamous epithelium. So this is a pattern of things to be aware of in this chapter. You want to know the order of all the different parts of the respiratory system, where the air moves. You want to know what type of tissue is at each part, what the function of each part is. That's going to be really key as we look at anatomy here. So the blood-air barrier is the place where gas exchange occurs. The diffusion of the air is really fast, the distance is short, and the concentration gradients are super high. Oxygen and carbon dioxide are lipid soluble. That means they're going to be able to move through the cell membranes without a lot of problems. Again, the surface area is really large with those alveoli, and that surfactant, which is so essential for keeping alveoli open, because surface tension of water would just mean that they collapse. So here is that blood-air barrier. We've got our alveolar cell level, and then the basement membrane of the alveolar epithelium and the capillary endothelium is fused. So they share a basement membrane. You can see the thin layer of surfactant covering the surface. Here is a red blood cell in that capillary lumen. And then we're remembering that those endothelial cells, they're actually cells. They're not just a layer of tissue, but are truly cells. So this is the blood-air barrier. Another help as you prepare for the exam, matching the letters with the descriptions. We've got lots of vocab for this, and vocab that happens at different levels of the respiratory system. So be aware of that. And the answers for you as well. So we're going to talk a little bit about respiratory physiology, and that's how do we breathe. So first, we've got to get air in and out of the lungs, and this is known as pulmonary ventilation. So we're ventilating, moving the air in the lungs. Inspiration is the word to move air into the lungs, and expiration is what we use to describe moving the air out of the lungs. Inspiration requires contraction of that diaphragm and the external intercostal muscles to expand that thoracic cage. And so here you can see your external intercostals, you can see the diaphragm. When these contract, we lower the pressure in the lungs. There is less pressure here, and so more pressure in the air in the environment. So the air is going to move from more to less pressure and fill the lungs. And then there are other muscles that can help. So your sternocleidomastoid can help, your scalenes, your pectoralis minor, your serratus anterior. Those are going to be helpful as well. And then for expiration, you're moving air out of the lungs, but it's mostly passive. So once these muscles relax, the thoracic area is going to return to its original volume. That means there's going to be more pressure in the thoracic cage. That means there's compared to the outside air has less pressure. So we're going to have air move from the higher pressure respiratory system into the air outside. So things we want to know and remember, it is a continuous column of air from the pharynx to the alveoli. So we don't just take air in like little bites like we do food. It is all one continuous column that's there. And this spot from the pharynx till just before the alveoli can be called the anatomic dead space. So it's the conducting portion of the respiratory system where there's no gas exchange happening. And so that's what dead space means, is it's just holding the air, it's moving the air, but no gas exchange is happening. Remember, lungs are sealed within the thoracic cavity. It's a vacuum in there. That's why it's a big problem if you have a wound that goes from the outside into that pleural cavity that's no longer a vacuum. You're no longer going to be able to get those lungs expanded. The lungs will stick to the thoracic law by the pleura. So there's some fluid in between, but they're not, that kind of helps keep them open and aerated. And then we want to remember Boyle's law. This is the law that's controlling that mechanism of breathing we just talked about. So pressure of gas is inversely proportional to volume. So is a fancy way of saying as volume increases, pressure goes down. So once again, here we are with our lungs. In inhalation, the volume of our chest cavity increases. The pressure of the outside air is greater than the pressure inside. And so the pressure inside has decreased and air is going to flow in. And it's these active muscles, so the active diaphragm and external intercostals, that are going to cause that volume increase. And now when we relax those muscles, we have a volume decrease. The pressure outside is less than the pressure inside. Because we have less volume, the pressure inside has increased, and so the air is going to flow out. So take a minute to look at this question and then choose the right answer. I hope you realize that as the diaphragm and external intercostal muscles contract and the volume in the lungs increases, according to Boyle's law, the pressure is going to decrease and we're going to have inspiration. You make sure that you understand this really well. This is going to be important. So how do we measure the volume of air? Because if the volume and pressure are so related, if we can track the volume, we can do a lot to track the pressure. And this is through a spirometer. So we're going to have lots of different measurements of air in the lungs. So it may be helpful to keep track of these. Because you're going to be able to calculate a lot of different things through them. So the tidal volume is the amount of air that moves with each breath, and that's always about 500 milliliters. Tidal volume, think of the tides. They come in and they go out. Nothing special every breath that we have. Your vital capacity is the total amount of air you can move in and out. So your vital capacity is, if you're taking a little bit in and then taking a little bit, pushing some out. And your vital capacity is going to include your inspiratory and expiratory reserve volume. And so this is some volume that's in your lungs, but it's not going to come out with each breath normally. You're going to need forced movement with muscles to make that air flow in or flow out. And there is some air that you're never going to really be able to move, and that's called your residual volume. Some air is always going to remain in the lungs. And so when we talk about, well, how much air can the lungs hold, we're going to be talking about what's called total lung capacity. And we're going to see that in our next diagram, but that is vital capacity. So the amount of air we can move in and out when we're using all our muscles and efforts, and then the residual volume, the amount of air that's there all the time. So here is A graph of the spirometer. You can see the nose is closed. We're measuring all the air going in and all the air going out of this individual. So here we've got just up and down. This is normal breathing. This is our tidal volume. And when we ask the patient here to breathe in as much as possible, we're going to get maximum inspiration. And that's going to include, we're going to put in our inspiratory reserve volume. And then we're going to ask for maximum expiration. That's going to see what our expiratory reserve volume is. And when we combine our inspiratory reserve volume, our tidal volume, and our expiratory reserve volume, that's our vital capacity. So that's the maximum amount of air we can move. Notice we've not touched the residual volume at all. There's always some air in the lungs, but when we add our vital capacity and our residual volume, we're going to get total lung capacity. So interestingly, males will have more inspiratory reserve volume and expiratory reserve volume compared to females. And because of that, they're going to have more vital capacity and total lung capacity. But the thought is females have less muscle, they have less metabolism demand, maybe they have less demand for oxygen, and so they may not need as much total lung capacity and vital capacity. Interesting to think about. So some formulas here. So remember, vital capacity is your expiratory reserve volume plus your tidal volume, that's VT, volume tidal, plus your inspiratory reserve volume. And that's the maximum amount of air you can move out. If we're asking for just inspiratory capacity, that's tidal volume plus inspiratory reserve volume. And that's the amount of air you could inhale after a normal expiration. And then we're going to look at respiratory minute volume. It's also abbreviated VE, and that is our respiratory rate, here designated as F, times the tidal volume. And that's telling us how much air are we moving in a minute. So for example, if our tidal volume is 500 milliliters, and our respiratory rate is about 12 breaths per minute, then our respiratory minute volume is going to be about 6 liters of air per minute, because we've multiplied the 12 times the 500 to get about 6 liters. So the gas exchange happens through through external and internal respiration. So external respiration, I think this is what we're more likely to think of with the lungs. This is exchange of gases between blood and the external environment, so the air. And it happens across the blood-air barrier. So we've got the alveolar air and the alveolar capillaries. This is what we've been talking about. But we also have internal respiration, and that's exchange of gases between the blood and the tissues. And so looking at these images, here is our external respiration happening in the lungs. We've got diffusion of oxygen and carbon dioxide to our red blood cells. And then from external respiration, we're going to go to internal respiration, where we're giving that gas to the tissues. And recognize that this gas exchange is kind of in opposition to pulmonary ventilation, which that ventilation is just moving air. There's no gas exchange happening. Hypoxia, hypo meaning less, oxia related to oxygen means you're not getting enough oxygen, and anoxia meaning you're not getting any oxygen. And so there's 3 ways that this can happen, and you probably want to keep track of these 3 ways. You can be hypoxic if you can't get oxygen to the lungs. So that's number 1. For example, you're choking, it's blocking the airflow. You can be hypoxic if you can't absorb oxygen across the epithelium. And so that would be something like in cystic fibrosis, when the mucus is too thick, you may not be able to absorb oxygen against that epithelium or across that epithelium. And you could be hypoxic if you have damage or poor blood flow from either a heart attack or a stroke or anything that's going to mean less oxygen gets to the alveoli. So kind of you can have problems before the alveoli, at the alveoli, or on the side of the cardiovascular system, bringing oxygen to the alveoli. So looking here, we're going to look at partial pressures. And this is using Dalton's law. And partial pressures describe the pressure exerted by a single gas or a mixture of gases. For me, it's not the same as concentration by any means, but it is going to flow from high to low like concentration does. And so you can kind of track the movement of the gases that way. So here we are in the lungs for external respiration. Our blood is coming in. It has a pretty low oxygen level, a high carbon dioxide level. It's going to come in contact with this blood-air barrier. The oxygen is higher in the alveolus, so it's going to move into the capillary. The carbon dioxide is higher in the capillary. It's going to move into the alveolus to be exhaled. And now we've got oxygenated blood going to the tissues. And there we're going to go into internal respiration. So here is our, and notice this pressure of oxygen, this should be higher than it is. So this is an error in the slide. So please note that, we want that number, it's going to be more like 95. So error in the slide and in the image. Here we've got this oxygenated air. We've got not a lot of carbon dioxide. We're internal respiration, so we're using the interstitial fluid and it's going into the cells. The oxygen concentration is higher in the capillary than in that interstitial fluid. So oxygen will move to the interstitial fluid. The carbon dioxide is higher in the interstitial fluid than it is in the capillary. So it's going to move into the capillary. And now we have deoxygenated blood, which is going to return to the lungs for external respiration. So know the difference between these two, where they happen, what's moving where, and what that means about the partial pressures. I don't want you to remember the numbers, but I want you to be able to express that the blood coming in for internal respiration has a higher partial pressure than the interstitial fluid, and that's why the oxygen moves out of that capillary. That's the kind of things we want to remember. So question here for you, take a minute to read and pause the video if you need to. So I hope you know that the exchange of gas between the atmosphere and the blood is known as external respiration. And this is just a text version similar to what we just talked about. External respiration and internal, all this diffusion is based on partial pressures. Carbon dioxide in external respiration has higher pressure in the blood, so it's going to diffuse out into the lungs. And this is carried on by carbonate ions. We're going to talk about carbon dioxide movement and how it's carried. Oxygen in external respiration has a higher pressure in the atmosphere, so it's going to diffuse into blood. And that's carried by hemoglobin, which when oxygen is attached is oxyhemoglobin. Internal respiration, exactly the same principle. Just the gases are moving a different direction, and it's due to the partial pressure differences and differences between blood and tissues. So here we're seeing that movement of here the external respiration, here the internal respiration. We've got carbon dioxide here on the left side, oxygen on the right side. What I really want to point out here is how carbon dioxide is handled and managed. We are familiar with oxygen and with hemoglobin, but carbon dioxide is transferred in the body a lot as the bicarbonate ion. And that's because carbon dioxide and water will form carbonic acid. Carbonic anhydrase will take that carbonic acid and turn it back into water and carbon dioxide. And then that carbonic acid in the blood is going to break down into bicarbonate and hydrogen. And this is super important because if we have a lot of carbon dioxide, this buffer system, we're going to absorb as much as we can and kind of keep that as homeostatic as we can, but we'll end up with more hydrogen ion and bicarbonate ion because more carbon dioxide on this end is going to push the reaction this way. And when we've got more hydrogen ion, that's going to make the pH lower. And so pH of the blood is one way that we can evaluate how much carbon dioxide is there, which helps us evaluate what is the body doing metabolically, how is the respiration going on. Also recognize that carbon dioxide is transported 3 ways through the tissues. So it can be just dissolved in the plasma as carbon dioxide. It's not shown in this little image, but you can imagine a little CO2 here. It can be bound to hemoglobin. So we've got a little bit of carbon dioxide on the hemoglobin, but then also we can have it converted to bicarbonate, and that's what happens in these red blood cells. And that bicarbonate will end up in the plasma. So we've got 3 ways to carry that carbon dioxide, and we're looking, keep track of where the partial pressures are for external and internal respiration. So we know how the gas moves, we know how the air moves, but what's controlling everything, that's the nervous system. And so we know our normal respiratory rate is 12 to 20 ventilations per minute, breaths per minute. And this is specifically controlled by the respiratory center, the respiratory control center in the medulla oblongata. It's what sends messages to the diaphragm and external intercostals. Those are going to change the volume, change the pressure, and make air flow. And there are several sensors involved. There are stretch receptors. So we want to make sure when we're breathing, there's no overstretching of elastic lung tissue. That can be a real problem. And then there's also chemoreceptors that are sensitive to carbon dioxide. And these will limit you holding your breath for a minute, because it's those chemoreceptors that kick in when there's too much carbon dioxide. The oxygen chemoreceptors are not really that sensitive. So instead of measuring oxygen, we do a lot more measuring carbon dioxide. And just a reminder, the medulla oblongata is in the brainstem. That's an AP1 flashback. So we have our respiratory rhythmicity centers that are going to generate the cycles of contraction and relaxation in the diaphragm. They're going to establish the pace, and they're going to modify that activity. So here's our medulla in the brainstem. I'm not focused on you learning these different complexes and different respiratory groups, but mostly really be aware that those controls are in the medulla oblongata. So question, take a minute to answer it. Which of the following parts of the brain controls respiration rates? I hope you knew that was the brainstem, the medulla oblongata. And now we'll look at some disorders of the respiratory system. So in the upper respiratory system, we can get viruses, we can get sinusitis, we can get tonsillitis, we can get laryngitis. All of these, we've got the itis ending, so it's inflammation. In the lower respiratory system, we can get acute bronchitis. So this is bronchitis that it's not been going on for forever. We can get pneumonia. So that's infection of the lower respiratory system, or something like tuberculosis or consumption. So tuberculosis is carried by a mycobacterium, which is a special bacteria that lives inside of cells. Really difficult to control and to kill. Used to be called consumption, but tuberculosis now, still a huge problem in the developing world, which is really sad because it is actually treatable and curable. But getting the treatments that are needed and having anyone interested in supporting the treatment of that is challenging. They are seeing more and more multi-drug resistant strains of tuberculosis. And so that is also very challenging to treat, though totally doable. If you like to read, and they have a great audiobook too, and there's a chapter on a free podcast. The author John Green, who wrote The Fault in Our Stars, wrote a book recently called Everything is Tuberculosis, and talks about how tuberculosis was so common for so many years that it set the standards for beauty, set the standards for how things work, and really formed our modern world. Really interesting because it was so common for so long. We've got restrictive pulmonary disorders, restrictive meaning the lungs are restricted into how much they can move. And so things like pulmonary fibrosis, this is where asbestos comes in or other particulate matter. You get buildup of connective tissue. It's no longer elastic. It doesn't allow for as much expansion, so you're going to have trouble breathing, and you'll have reduced compliance. So not only can it be restrictive in that the fibrosis material is in the way of expanding, but compliance, if the lungs are not able to expand, that can be a big deal. We've got obstructive pulmonary disorders. So these are things like chronic bronchitis or asthma. This is where you are not able to get air where it needs to be, either because there's infection there, or the airways are narrowed. And then you can also get emphysema. And emphysema actually seems strange because you've got increased compliance, which you think would help, but the problem is the alveoli are bursting and fusing into these big spaces, and because they are bursting, you don't have as much surface area, and so you can't exchange as much gas. Lung cancer is seen in the respiratory system, and up to 90% of them are related to smoking, tends to be really aggressive, and it's usually those epithelial cells which would have been in contact with the carcinogens of smoking, and this includes chemicals that we would see in vapes as well. And it tends to be aggressive. There is benefit, though, to quitting smoking. There is a graph in the book that shows if you quit smoking, or if someone quits smoking at a certain age, how does that affect their chance for lung cancer and long-term disease? And quitting at any time offers less chance of having cancer of the lungs. And one of the treatments is pneumonectomy. Ectomy means cutting out of something, so they will go in and remove a lung lobe or a piece of the lung that has the cancer, trying to treat it. But that helps if it's only in one space. If it's all over the lungs, that can be a problem. And then recognizing cancer of the lungs can be primary, so start in the lungs, but the lungs are also a place where metastasis goes. It's got a lot of blood flow, got lots of cells with that are really narrow, that blood-air barrier, really easy for a cancer cell to pass through. So you can also see metastasis of cancer cells in the lung tissue. So that's it for the respiratory system. And I will see you for the next video. Bye.